Thank you, Paul and Warner, for the invite. Really a pleasure to be here and to be speaking to all of you today. Also, I should mention, I also was a TAPS fellow at CAPS, so Traineeship in AIDS Prevention Studies with Carol. Actually, we were co-fellows at the time, and had my first grant to do primary data collection through a CFAR grant as well, which was studying actually household TB transmission. My interests are both in HIV and TB, their intersection, and their roles as leading pathogens as causes of death in East Africa, and particularly in Uganda and Kenya. But that first grant, I'll just say briefly without digressing too much. By the way, I have no back tattoos or pictures of myself and my sister, unfortunately, but that first grant really pushed me to get outside of my comfort zone and meet and collaborate with people smarter than I that were doing very interesting things in other fields. So my first grant was looking at household ventilation and measuring using carbon dioxide out in the community, air changes per hour, which are a metric of potential for TB transmission environments. That then led me into looking at community TB transmission in a K-23, and actually just really got me thinking, pushing aside from thinking about other disciplines and how to work with people with completely different disciplines. I'm going to talk about that today, but also about getting out in the community and meeting people where they are. I'm a clinician by training at UCSF in infectious diseases, so a lot of that work was just formative in how I've been fortunate to have my research career come together. So today I'm going to discuss interventions to promote HIV testing and retesting in Africa, in East Africa specifically. And I'll start by saying I'm going to move quickly. Actually, I'm going to spend only a little bit of time on search, talking about the search study that Paul had mentioned, and then talk more about specific trials we've been doing to test interventions to try to increase HIV testing uptake. So I realize I'm speaking to the choir on many of these topics here, but we do have the biomedical tools to eliminate HIV transmission, both in terms of antiretroviral therapy with viral suppression and the U=U movement. And this, by the way, is clearly, at least in San Francisco, understood by patients. Of course, pre-exposure prophylaxis and other combination prevention approaches that can eliminate person-to-person transmission. But I think, as we all know, a variety of factors, including behavioral and economic factors, limit their effectiveness. And it's just interesting to note that even conditions like measles, completely vaccine preventable, or syphilis cured with a single shot of penicillin in cases of early syphilis persists. In fact, incidence is going up, as we're all well aware. So these factors are, I think, highly germane regardless of, even as biomedical tools improve. Now, HIV testing is the first critical step in accessing prevention, treatment, and thinking about individualized HIV education and counseling for patients. And the WHO, and UNAIDS estimates that roughly 25% of HIV-positive people globally are unaware of their status, and suggests that the first gap, the first 90 of the 90 targets is really the largest gap. And as I became involved and had a pleasure of working with a really exciting group of people on, including Moses Kamya in Uganda, Elizabeth Kusi in Kenya, and my primary mentor, Diane Havlier in San Francisco, Maya Peterson in Berkeley, a long list of research collaborators, really we began thinking of how to, along with the whole field, but what are ways to overcome challenges in HIV testing? Because clearly the old model of having a facility and putting up a sign saying come and HIV test here led to pretty low rates of HIV testing, and when people did come, they were quite symptomatic and late in infection. So I'm summarizing a huge amount of work from really the whole HIV field, but clearly many barriers to HIV testing have been identified, and many interventions have been developed. Some of those barriers, to summarize, include a lack of awareness of risk, or perhaps lack of symptoms, or a lack of awareness that maybe acute retroviral syndrome is related to HIV. Moving into more provider-initiated opt-out testing interventions have really tried to get away from that. So maybe you come into the clinic for some other reason and you get an HIV test and get diagnosed. Clearly, stigma is still a huge worldwide problem. And one of the ways that we sought to address this, as I'll talk about briefly, was incorporating HIV really as part of broader healthcare. So offering more than just HIV testing, but thinking about multi-disease screening. So you may not be interested in HIV testing. Maybe you're interested in why your foot is hurting, or you're getting checked for hypertension or diabetes, but adding HIV as part of that. Or if you're interested in HIV testing, providing other tests as in essence cover, so you're not disclosing to the world that you're going to HIV test when you access services. As I mentioned, getting out of facilities, so distance, particularly in rural sub-Saharan Africa, is a prohibitive factor in accessing testing and healthcare. And so out-of-facility testing approaches, such as home-based testing, and what I'm going to talk about briefly, which are community health campaigns, so going out in the community and offering health services, can lead to increases in HIV testing on a population level. In terms of lack of trust in the health system and not necessarily wanting to even go to a healthcare provider or trusting that environment, Carol mentioned self-testing, really an exciting innovation in terms of perhaps getting a test from someone you trust and reaching people that way, as well as index testing. So having someone who's newly infected or at risk who then offers tests downstream to their connections, social connections. And then in terms of cost and time, which I'm going to focus on a bit today as well, certainly rapid testing and rapid algorithms have made this testing point of care and allowed people to test much more quickly. So briefly, the Search, Test, and Treat trial, the first phase of it, which was to test the approach of a universal HIV testing and universal HIV treatment approach, offering everyone with HIV antiretroviral therapy that was identified in these 32 communities in East Africa to see if it could have an impact on cumulative HIV incidence over 3 years. One of my charges as I began working on this was an effort to maximize testing, to see if you could test entire communities for HIV. And we used a novel hybrid testing approach where we combined, as I mentioned, these broad community health campaigns after conducting a baseline community enumeration. And for the people that were not present at the campaign, we then offered subsequent home-based testing really immediately after to try to increase testing as much as possible. And in Search, we, working with a really incredible team on the ground, and community members, we exceeded the 90-90-90 targets in the 16 intervention communities. So these are communities of about 10,000 people each after 2 years. And focusing specifically on the HIV testing, at our first pass, we tested roughly the first 90% and then 94% at 1 year, 96% at 2 years with these iterative testing campaigns done annually. And this is just to give you a sense of what this looked like. So first we had a community census and mobilization, followed by these multi-disease health campaigns, and then home-based testing of non-participants. This happened in intervention and control communities, but in interventions it was repeated twice. I won't dwell long on this, but if you walk through kind of a virtual tour of what it might entail, we had mobilization efforts such as football matches and other attractive things to draw community members to the event. We used tents, which are really celebratory kind of a sign for weddings and other celebrations, religious celebrations in Uganda and Kenya. And we also went to where people are. So this is an example on the shores of Lake Victoria within communities. We provided group health education and not restricted HIV, welcomed people where we did measurements, and then we had really multi-disease offerings, including blood pressure measurements, screening for diabetes, HIV, malaria, with one-on-one post-test counseling, deworming and vitamin A for children, a raffle, and thank you at the exit. And just to show some of the, this is what we published on our first year of testing. If you take pre-campaign, red being areas that are, these are individuals that are, heat maps of individuals that are untested for HIV, but blue means they're tested, and there's some fringe effect here, but after the campaign, we really decreased the number of people who have never tested, and after the home-based testing, this hybrid approach, decreased it even further, so that the vast, well, 90% of people had tested. So a question that now comes up then is who remains untested in the post-90-90-90 world, and there's many answers to that, but in this context, following 3 annual rounds of hybrid testing, we did go back and ascertain the vital status of all adult residents, and overall, we achieved 98% testing coverage after the intervention communities with repeated testing. And when we try to characterize or look to characterize those who had never tested for HIV, one thing I want to highlight here is that male sex in these communities, being a man, popped out as a reason for, as a risk factor for never testing despite these repeated efforts to test. And this is just after our first year, so intervention and control, we went in and tried to test everyone. You can see that really across all ages we see disparities where women here in red and men in blue, men are consistently testing at lower rates than women. And this is something that's been described in a variety of settings across sub-Saharan Africa, and even in settings that have achieved this greater than 90% testing target. And the gender disparity that we see in testing really spills out throughout the rest of the care cascade. so that HIV-infected men, along with entering care with more advanced disease, remain less likely to receive antiretrovirals. They have higher mortality than HIV-infected women. And in 2015, WHO guidelines really there was a call to action of interventions to increase testing among men. So as we thought about this challenge, I had the pleasure of one of my colleagues, Harsha Thirumoorthy, is an economist at University of Pennsylvania. He and I began talking actually through the search collaboration and started discussing ways to consider how people make decisions and economic theories of behavior. Could that offer some additional solutions on top of what we're already trying in community-based testing? So this is when I get into my not comfort zone as a clinician and talk about economics. So Richard Thaler is a well-known economist and Nobel Prize winner who described really this idea, and this is moving from a kind of a model that had dominated economics for a very long time of homo economists, this emphasis on rational choice perspective. And this is an idea that individuals are utility maximizers who make decisions based on preferences, careful weighing of costs and benefits, income and prices. The behavioral economics view really tries to shift this a bit and take advantage, instead of, through a series of experiments, observations, realizing that what is known about human motivation and behavior is not always rational, surprise, and that you could use this knowledge to potentially develop better understanding of choices and design interventions that use these insights for the better. So, for example, these are some common, you could call them decision errors, but they're really just decision tendencies in humans that can potentially be used to suggest some solutions to problems. So, for example, I'll go through them briefly, but a status quo bias is the tendency that humans have to take the path of least resistance or to do what comes automatically. And examples of this in terms of solutions is to really modify the path of least resistance through choice architecture and the use of defaults. And a classic example is in Northern European countries when they switched from a opt-in for organ donation when you're getting your driver's license to an opt-out, they saw really rates of people participating in organ donation skyrocket. In the same way, in our, not to say this is identical, but opting out of HIV testing, in our multi-disease health campaigns, we offered a slew of services. You didn't have to pick them, but you could opt out of any of them, and we made that clear. And we had extremely high rates of HIV testing acceptance, beyond 99%, because again, it's a path of least resistance in that regard. Another example is present biased preferences, and this is really the tendency that all of us have to overweight immediate costs and benefits relative to the future. So example solutions here are really to think about how do you make feedback immediate and frequent. An example of this is incentives that I'll talk a bit about, financial incentives, for example, conditional on a certain behavior. Daniel Kahneman and Amos Tversky talked about the overweighting of small probabilities, and this is the tendency that people tend to put disproportionate weight on outcomes that have very low probabilities of occurring. And an example is we often will, even in public spending, think much more, for example, about terrorism than about dying in a car crash when you're texting. So, and one of the ways to consider solutions for this is to consider probabilistic rewards for behaviors that one is interested, that might promote someone's health. An example here is lotteries, and I'll talk about how those are used for health promotion as well. Over-optimism, so this idea that we self-predict our future behavior way more optimistically than we actually do. I think we can all relate to that. And our future predictions are systematically biased towards being overly optimistic. So one way to consider leveraging this for a solution is through commitment contracts, meaning commit today to a future behavior, not to do something right now, but for something in the future, and maybe even put some money down so that you're, for example, join that gym, it might get you going to some extent. These are often termed nudges, trying to move people in a certain direction. And then lastly, loss aversion. So this is the tendency that all of us have to put substantially greater weight on losses relative to gains of sort of the same magnitude. And one way to consider solutions for this is to put rewards at risk if behavior doesn't change. I'm just thinking of what Satish was talking about before, and this is really, I realize, a shift. So in terms of some of these biases, one thing that is also clear in working in resource-limited settings is there's a growing evidence base that poverty may increase present bias. And not, I think this is somewhat intuitive, but there's a series of experiments and observations that in settings of scarcity, by necessity, increases humans' focus on, or the urgency and focus on present decisions and costs. I think you can imagine this. If you're really starving, it's hard to pay attention to a lecture, you want to eat. If you're really tired and listening to me, you'd rather take a nap. Then, so whatever's happening in the moment, I don't mean to be glib, but really can consume your attentional resources and make it much more hard or difficult to think about other decisions, particularly future decisions that are just not in the present. And some really nice lab and field experiments have demonstrated that poverty and states of scarcity can impede cognitive function in terms of decision-making capacity, even within individuals. So it's not, one example is a really interesting natural experiment of sugarcane farmers in India. These are the same people pre and post-harvest, and they did a variety of tests where they showed that ability to complete complex or tests accurately went up post-harvest when people were more flush with cash, and their ability to, their frequency of errors was higher pre-harvest. So clearly poverty interplays with present-based preferences. Another observation is that, not surprisingly, in poor countries, the price of health services impact their uptake and their use, so that as you moved from something being expensive to cheaper, not only does uptake increase for a variety of prevention behaviors, but the use of those behaviors by the people that are getting them goes up as well. This leads to a natural question, which is what do you do if the price is already zero? And incentives may offer one solution for that. And the reason is in a standard economic rationale, this reduces the cost and might increase the benefits of undertaking a behavior, but from a behavioral economic perspective, it really could take advantage of present-based preferences, and that's, again, paying more attention to the incentive now rather than what the preventive behavior might do in the future, such as HIV testing or using your BedNet. All right, so we sought to take these insights as a basis for improving HIV uptake in East Africa. And we did it in two ways. The first was to look at could we use this to increase HIV testing coverage among men? And the second was to promote HIV retesting, so testing, again, even if you've tested negative, in high-risk adults. And the focus of Harsha's and mine and our team's work was in rural southwestern Uganda. So let me step forward. So make sure I stay well within my time. In terms of incentives in HIV testing, there's a good amount of evidence that standard incentives, we refer to them as gain-framed, so if you do behavior X, you get a gain, can promote health behaviors, including HIV testing in a variety of settings. In our first trial, what we sought to do is see if you could take behavioral economic observations and build them in interventions for the incentives to make them essentially better than your standard gain-framed incentive. And we looked at this in two ways. One was using this idea of lotteries, so overestimating your chances of winning, and the other was loss aversion, or having loss being more motivating than gain. So our first trial, we randomized adult men in 4 parishes in rural southwestern Uganda to 3 types of incentives at 2 different amounts to participate in a community health campaign that I've described. The 3 types of incentives were first a gain-framed or just standard conditional incentive if they HIV tested at the campaign. They told they'd receive a prize. These are non-cash incentives. The second was loss-framed. This isn't exactly loss aversion, but it's trying to elicit loss aversion, and it's this idea that you would congratulate someone on winning a prize at the time they were being enrolled and told about the campaign. You're actually shown the prizes to try to create a sense of ownership. They're asked to choose specifically from some of the choices that were available at the campaign and given a card to hold on to it, of the card that they chose, saying, this is yours, you will get it just once you come to the campaign, it's yours to pick up. But it was emphasized you will lose your prize if you don't come for HIV testing. And finally was this lottery idea that if you test for HIV, we'll automatically enter you into a lottery with a chance to instantly win a large prize, such as a bicycle or a mobile phone. And we looked at this at low amounts at $1 prizes or at high amounts at $5 prizes. These are I won't go long on it, but these are how it looked to the participants and the RAs. So the gain framed was know your status and get a reward. Loss framed, know your status and claim your prize with the pictures of the prizes. Or the third arm, know your status and enter to win a prize. And I'll focus on our primary hypothesis was that the lottery and loss-framed incentives would result in significantly higher testing uptake than standard gain-framed incentives. So we randomized men to these different strategies, and our primary outcome was testing uptake at the campaign. Here are our enrollment numbers, and I'll briefly say that we didn't see significant differences across study arm. This is our table 1. And the median daily wage in this group of community enrolled men was $1, with 48% reporting that they had HIV tested in the past 12 months. So overall, 76% of men tested for HIV at the campaign, and the prevalence among those tested was 7 to 8%, which is roughly the prevalence we found in this area of Uganda. And 51% reported they were newly diagnosed. That's by self-report. And overall, we saw a trend towards increasing testing with loss framing and lottery framing compared to gain frame, but these were not significant differences. When we looked, however, by the dollar amount in the low-cost incentive, so US or $1 per participant, we did find, this is secondary analysis, we found a bump significantly greater testing participation in men randomized to lotteries compared to your standard gain-framed incentive. This was not seen at the $5 amount. And we did not see a difference between $1 and $5 groups compared directly. Okay. So in summary, we didn't see a significant difference in testing uptake with the lottery, the loss framed versus the gain framed incentives overall. But we did find that in the low cost groups, there was a significantly higher testing uptake if you used the lottery compared to a gain framed, suggesting potentially this nudge effect of using this lottery type incentive. And we did not see a significant difference in HIV testing at higher versus lower cost incentives. So a conclusion of this trial that was published in AIDS this past year is that the effect of the incentive type did differ by, the effect of the incentive differed by the incentive type. Let me rephrase that. The effect of the incentive type differed depending if you were $1 or $5. And this may be because there's something referred to as the peanuts effect, but essentially people may be more willing or excited about a lottery when you're comparing it to really low stakes like $1. And so they're more willing to, they're excited about a lottery at $1 where the prizes are higher than the $1 certain gain. But when you get to higher value amounts, like 5 times your daily wage, that kind of flattens the effect so that the certainty of a high value gain becomes quite appealing. So the gain framed incentive there might have been more appealing as a result. Let me move quickly. I realize I'm running a bit out of time. So for our second trial around testing, this is an ongoing trial. I'm going to share some preliminary data. But we sought here to assess the effectiveness of commitment or deposit contracts, as well as gain-framed incentives like I just described, the conditional cash transfer, compared to no incentive to promote retesting in key populations, men and women here, who have tested negative but are high risk, and they are recommended to come back for repeat testing at 3 and 6 months. And what we tried to leverage here of those lists of behavioral kind of economic decision-making principles was to think about how do you generate loss aversion, and one way, again, is a commitment contract. And it's this idea of a binding agreement with oneself that's entered into voluntarily, but to utilize loss aversion to try to ensure that an activity is completed. So you can deposit money or an item in the beginning, and you know that you're at risk of losing that if you don't complete the behavior that you want to. And this has been used in the US and shown to motivate participants towards various types of behavior change, but has not been used, I think, due to ethical concerns of people not having a lot of funding available in resource-limited settings. So I should say we did conduct a pilot first and found high acceptability and feasibility of low-level or low-cost commitment contracts that then led to this larger trial. So this is the design, and the enrollment is HIV-negative high-risk individuals who are randomized to either a control arm or they get an initial travel voucher for coming, but then there's no additional incentives if they come at 3 months and 6 months for repeat testing. And then the fixed incentive arm where people get this travel voucher, but then they come back at 3 and 6 months, and each time they get an incentive for retesting. Or a commitment contract where we give them a cash transfer at baseline of 10,000 Uganda shillings, so this is about $2.50. And you offer a deposit contract where they can put in a total of 15, so they can use the 10,000 they just got and add, supplement with 5, that they voluntarily would give to say, I commit this and I want to come back in 3 months, and this will help bring me back in 3 months. If they come back, they get that 15,000 back plus an additional 5,000 for a total of 20 to deal with the idea of earned interest over time. And they get a choice to redeposit. So we recruited from high-risk venues, and that included bars primarily for women and transport stages for men. say overall, the median age is 26. And when we looked at those who were screened, we screened about just under 1,500 people. It was pretty evident that in women who are often engaging in transactional sex and commercial sex work, the HIV prevalence was 33%, and this is in an area where it's roughly around 8 to 10%. So clearly in a high-risk pool of women, at least. And then enrolled 525 total into the trial. I realize I'm out of time, so I'll just briefly say that what we're seeing at 3 months so far, and we're not at the full 6-month measure of repeated testing, is that gain-framed incentives appear to be, and I haven't put significant tests here just to show you there's some raw data, but gain-framed incentives seem to be outperforming a control of no incentives. But the deposit contract is somewhat similar to the control. And part of that may be that, this has been observed in U.S. studies of deposit contracts too, is that only a small number of people were willing to participate in making that deposit. And that was 13% of people agreed to make the deposit. However, if they did make the deposit, the rates of coming for retesting were quite high. Okay, so on that I'll wrap up and just say that some final thoughts, which is HIV testing coverage has steadily improved over the past decade in sub-Saharan Africa, but these gains have not been evenly distributed, and overall men continue to test at lower rates than women in rural East Africa. And what we've been considering is how interventions that take decision-making and behavioral economic principles into account can increase HIV testing uptake in under-tested groups. And we're exploring not just HIV testing, but further areas of study, including adherence to ART, isoniazid preventive therapy, and contingency management to reduce heavy alcohol drinking in Uganda. I have many more people to thank than I can with my time allotted, but I really want to thank the IBIS team, that's the name of our study, and Harshat Thiramuthi, pictured here with me in particular as my co-PI. Our team in both UCSF and the US and Uganda, as well as the search trial team that's been really a wonderful group to work with, and I've learned an enormous amount. So thank you all.
So Gabe, I know it wasn't the focus of your work, but obviously the retesting situation would be a good time to think about PrEP.
Yeah.
Can you just tell us a little bit about what the status of PrEP in East Africa?
Yeah, it's a great question. So when it is just, I would say, starting to arrive in search, our second phase, when we started implementing PrEP in Kenya and Uganda, it was not yet available in MOH clinics. That is shifting. So it's becoming available. And of course, even those accessing PrEP need to be routinely retesting for HIV, as you all know. But it is becoming available, I'd say, but not quite there in Uganda. It's more quick uptake in Kenya at the moment.
Great. Other questions? Yeah, Jim.
Yes, it's a terrific presentation. Thank you, and it's very interesting to see these behavioral principles being applied across the globe. A question, I think it's more for Paul and the organizers of the meeting. The slides are also really great today, and I wondered if these would be available to the participants, or if we should write to or email the.
I'm happy to email. I will say that
directly.
Some of our most recent trial findings is still unpublished and the trial's ongoing. So but beyond that, I'm happy to share them. Yeah.
We'll do what we can, but obviously limited by unpublished data. Yeah.
Sure.
Thanks,
Thank
Jim. Werner. Yeah.
So you presented data early on about retesting in eastern and western Uganda and Kenya, and things look like they improved markedly in Uganda, but not so much in Kenya. Was that true?
No, there was increased testing really throughout. What I was showing was at search, in each iteration, we increased the proportion of people testing. We hit about a 90% one-time testing initially, and then with subsequent rounds, the ever testing proportion really approached close to 100%. And of course, a fraction of those were retesting every year in the intervention communities. Does that answer your question?
Well,
do you mean within the study?
I probably misinterpreted your slide.
My apologies.
That's my fault.
And just, I remember one presentation at one of the IAS meetings that made it though, that there were some ongoing problems in adolescence. I know that wasn't the focus of your presentation today, but can you comment on?
Absolutely. So I would say that overall, in terms of, in adolescence, we also exceeded the 90% mark. It took a little, the rates are slightly lower, but in search, this approach did lead to really high levels of ever testing. The question, though, I think when we all were wondering at the start of the test and treat trials, how often does one need to have population-wide testing for this, and to get really high rates of people on antiretroviral therapy? The model by Rubin Greenwich et al. In Lancet that kind of thought experiment around that was annual testing. That is what we did in search, but there, it really, of course, depends on risk.
Great. Geraldine, one last question.
Great talk, and I was really interested in the fact in the early part of your talk you presented those health fairs as a way to get people into testing, and you tested for things like hypertension, diabetes. What happens after that? I mean, is there a way to be put into care, or it was just a way to draw in?
No, we that's a great question. We linked people to care, and actually we've been publishing on our hypertension outcomes because hypertensive drugs are quite cheap and available.
So do you have good numbers that come back and link to care when it comes to the hypertension and diabetes?
It's a great question. With the co-infected HIV and hypertensives, yes. With hypertensive alone without HIV, also was better in intervention than control, and the rates are okay, fairly good. People are interested in engaging in care in that way. The delivery use of HIV chronic care models, not just, let me say it this way, the idea of a multi-disease approach for screening was not purely demand generation and you're on your own. So we really tried to screen for things for which there was treatment available at the clinic afterwards. And we brought that multi-disease model not just for screening, but to chronic care delivery. As you can imagine, also attending a clinic, it would be nice to go to a clinic for broad chronic care, not simply to go to an HIV clinic. And I think that transition is happening, but slower than one might wish. I think it's fair to say.